because it was novel and new and interesting at the time, and nothing had really been done to that point in time. And it was the ability to be able to identify patients with malnutrition when they were admitted to hospital. So we actually developed a screening tool to identify those patients who might be at risk of malnutrition when they first entered the hospital system, so that then we could actually, manage their malnutrition and monitor them through their hospital stay. No, not at the time. No, we knew there was a need, and at first it was being used in Australia, and it's probably been 10 years, and that's another thing that you learn in research is stuff can be published, but then actually getting it implemented into practice is another story. And we've found that it takes about 10 years to actually get things implemented in practice. That whole behaviour change takes a significant amount of time, and malnutrition is still being talked about today. It's like 15 years later, so it takes a long time to change practice. So the malnutrition screening tool that we developed is 2 questions, so it was designed to be very simple, very quick, that patients and their families could even complete themselves, and that it would actually be valid and reliable. So the 2 questions are, have they lost weight recently without trying, and also have they had a decrease in their appetite and or food intake. The tool's used throughout Australia and also globally, so it's used in the US, Europe, the UK, so yeah, it's been great to see that it's been implemented around the world. So what would happen is typically the nurses would actually complete the screening tool. In some cases, nutrition assistants who actually take out menus, particularly here at the PA hospital, nutrition assistants would complete the tool, and then either the nurses or the nutrition assistants would refer those patients to dietitians for assessment and then management. So the dietitians would do an assessment of the patients to see if they were in fact malnourished, so you can have the screening tool but actually find out they're actually okay. So they would do a more detailed assessment, looking at their recent history in terms of their symptoms like nausea and vomiting, their food intake, their appetite, their weight history, and then determine whether the patient is actually malnourished or not using a tool that we call subjective global assessment. Once they establish that the patient is malnourished, there's obviously a number of different options. Typically they'd be put on a high protein, high energy diet. Typically they would also receive oral nutrition supplements, so something like Ensure or Sustagen. However, if the patient isn't able to eat orally, then we may also consider a nasogastric feed, or in situations where the gastrointestinal tract isn't working, we'd actually look at total parenteral nutrition, which is feeding through the vein. We've done a number of studies now, and 30% of patients are typically malnourished on hospital admission, and that's both here in Brisbane, Queensland, but also we've done a study with one of my PhD students, Hector Agrawal, just recently, which was across Australia and New Zealand, and again the prevalence rates were about 30%, and that's consistent actually with global data. There are a number of causes of malnutrition. It can obviously be because you're not eating enough food, so there's obviously malnutrition in third world countries. Typically what we're talking about in countries like Australia is that it's related to their disease. So obviously patients with cancer often tend to lose weight. They've got chemotherapy, radiotherapy, which obviously affects their appetite. They've got nausea, vomiting, so all of those things impact on food intake, which leads to weight loss and then malnutrition. So cancer would be an area where they're very prevalent. Other areas might be respiratory disease or after surgery. A lot of conditions where you're, I guess, compromised by being in hospital. There's an association between nutritional status of patients malnourished versus well-nourished and their clinical outcomes. So patients with malnutrition tend to have longer lengths of stay, as well as higher rates of readmission and higher rates of mortality or death. So there's a link between nutritional status and poor clinical outcomes. Typically we haven't been able to separate the disease. That obviously is going to be significantly affecting those outcomes as well. But Hector Agrawal, who's one of my PhD students, recently did a study which showed independently that nutrition actually has an impact on some of those clinical outcomes, regardless of their disease status.